To assess the thorax, ask the patient to breathe normally as you observe his respirations. Respirations should be regular and symmetrical, and the accessory muscles should not be used. The patient should breathe comfortably while sitting with his arms at rest. Now move around slowly to the patient's back. As you do this, assess the anteroposterior and lateral diameters of the thorax. Normally, the lateral diameter is up to twice the anteroposterior diameter for a ratio of about 2 to 1. Still standing behind the patient, use your finger pads to palpate the spinous processes. They should be evenly spaced and non-tender. Next, assess respiratory expansion. To do this, place your thumbs at the level of T10, or the 10th thoracic vertebra. Spread your fingers, allowing for small folds of skin between your thumbs. Ask the patient to take deep, slow breaths. As he does, watch your thumbs move with respiration. Their movement should be symmetrical. Next, assess for tactile fremitus, or voice sounds palpated on the chest wall surface. Using the ball of your hand, feel for vibrations as the patient repeats the phrase 99. Move from the apices inside the scapula down to the lower and lateral thorax. In each location, you should feel equal vibrations.
99.
Now perform mediate percussion using a systematic pattern so you can compare the two sides. Resonance should be equal over the lungs. You should hear dullness over the diaphragm. Hyperresonance means you found an area of increased air in the lung or pleural space, as with a pneumothorax or acute asthma. Abnormal dullness indicates decreased air in the lungs, as with atelectasis or a buildup of pleural fluid. Now assess diaphragmatic excursion. To do this, ask the patient to exhale and then hold his breath. As he holds his breath, percuss from the scapula down to where the sound changes from resonance to dullness. Mark this spot with a pen. Now ask the patient to inhale deeply and hold his breath as you percuss further down to the new area of dullness. Mark this spot too. Repeat this process on the other side. Measure the distance between the set of marks on each side. Normally, this distance, which represents diaphragmatic excursion, measures 3 to 5 centimeters and is equal on both sides. Next, assess the kidneys using blunt or fist percussion over the costovertebral angle. Percussion in this area should not cause tenderness. Finally, auscultate breath sounds with the diaphragm of your stethoscope. To do this, instruct the patient to breathe deeply through his mouth. Starting at the lung apices, auscultate the lungs. Move systematically from side to side down the patient's back and laterally toward the axillae. Be sure to listen for at least one complete respiration at each location. Normal breath sounds vary with the area you're assessing. You should hear bronchovesicular sounds between the scapulae. These sounds are moderate in pitch and amplitude, with an inspiratory phase equal to the expiratory phase. You should hear vesicular sounds at the apices, down to the bases and laterally. These sounds are low-pitched and soft, with a longer inspiratory than expiratory phase. Listen for abnormal sounds, such as crackles and wheezes, and for coughing and abnormal respiratory effort. If you hear crackles or wheezes, ask the patient to cough. Then listen again to determine if the abnormal sounds have cleared. Crackles, which can be heard on inspiration and sometimes on expiration, result from collapsed or fluid-filled alveoli popping open. They have a fine crackling or sometimes a bubbling sound. Wheezes, which can be heard on both inspiration and expiration, are high or low-pitched. They indicate airway obstruction. If you suspect an abnormality, have the patient say 99 as you auscultate
99.
these areas.
99.
Again,
99.
again.
99.
Normally, the words sound muffled and indistinct. To assess the patient's anterior thorax, begin with the bones and muscles. Normally, they appear symmetrical, and you should not see accessory muscle use, retractions, or bulges. The patient should not have signs of respiratory difficulty, such as cyanosis or nostril flaring. Next, palpate the thorax with your finger pads, moving from the lung apices to the bases. You should find no nodules or tenderness. To assess respiratory expansion, place your hands on the patient's chest along the costal margins, with your thumbs pointing toward the xiphoid process. Have the patient take a few deep breaths. As he does this, watch your thumbs. They should move simultaneously and symmetrically. Now assess for tactile fremitus as the patient repeats the phrase 99.
99.
Move from the lung apices down to a
99.
point below the nipples, comparing sides.
99.
Vibrations should feel
99.
equal but stronger in the upper chest than the lower chest. Next, perform percussion over the lungs, using a systematic approach. Start just above the clavicle and percuss in the intercostal spaces down the chest from side to side. Percussion should produce low resonant sounds. Then auscultate over the patient's lungs with the diaphragm of the stethoscope in the same pattern you used for percussion. At each location, listen for one complete respiration. Normal breath sounds vary with the area you're assessing. You should hear tracheal sounds over the trachea. These are high-pitched, loud, and tubular. You should hear bronchovesicular sounds laterally and over the bronchi at the angle of Louis. Expect to hear vesicular sounds over most of the anterior thorax and the periphery. If you suspect an abnormality, have the patient say 99 several times as you auscultate the
99.
areas involved. Normally, the words sound muffled and indistinct.
99.